Hi, everyone. Good evening, all of you. Okay, fine. So we are going to start with eating disorders. Eating disorders. See, all of you, you can type in the chat box there. Like overall, how many eating disorders you know? How many eating disorders you know? Okay, fine. All right. So first of all, yes, a very common anorexia nervosa, bulimia nervosa, right? Anorexia, bulimia, okay, binge eating disorder, all these. All right. Now, let's start with the basics of eating disorders. After that, we are going to learn about the clinical aspects, okay, clinical aspects of eating disorder, how to handle the case. So do you think eating disorders can be very serious? Overall, do you think eating disorders can be very serious? Overall, do you think so? All right. Okay. See here. When I talk about eating disorder, see, let's learn about, first of all, anorexia nervosa and then bulimia nervosa. Anorexia nervosa and bulimia nervosa. The question is that this is very common among male or female. Please answer me. This is more common among male or female? Eating disorder more common among male or female? Yes, very good. Very good. Remember it? See, this is more common among females. This is more common among females. Much more common among females. Much more common among females. If you see the ratio is 10:1. First of all, let's understand the basics of, eating disorder. After that, I will teach you how much eating disorder can be serious. How much eating disorder can be serious, right? Okay, fine. Let's understand this part first of all. We have to hospitalize the patient also. We have to do the accurate management also. Okay, fine. So first of all, the basics. In which age group eating disorder is common? In which age group eating disorder is common? Obviously, among youngsters. Remember here, among youngsters, it is common. So first of all, do you understand here that? First of all, do you understand? Eating disorders are more common in adolescent age group. Adolescent age group. So this can be early and this can be late. Okay, this can be early adolescent and this can be late adolescent age group. Okay. Eating disorder can be seen in early age also. Early age also. Early adulthood. Early adulthood. What is the most common eating disorder which is seen in the early adolescent phase? It is anorexia nervosa. Anorexia nervosa. Late adolescent, bulimia nervosa. But when I talk about early adulthood, what is the most common eating disorder which will be starting in early adulthood? This is binge eating disorder. This is binge eating disorder. Binge eating disorder. Overall, which eating disorder is most common? Remember here, binge eating disorder is the most common eating disorder. Most common eating disorder. Now let's learn one by one. The question is why there is eating disorder? Why there is eating disorder? Especially see eating disorders, this will start in the adolescent age group. Very early age group. Youngsters, among the teenagers, because most of them are what? Image conscious. These people are what? Image conscious. These people are what? figure conscious. They will be having what? Fear of weight, fear of weight, fear of weight gain. Look at her. She seems to be very much slim and trim, but whenever she is looking herself in the mirror, she thinking, oh my, I've become fat. Oh my God, I've become fat. I've become fat. What is this? She is getting what? Image. She's having what? Image consciousness. Okay. Image consciousness. Very easy to understand. All right. The question is, when a female will be image conscious, figure conscious, fear of weight gain, what will she do then? Either she is going to stop eating food, she will be having what? So much exercises, or even if she eating the food, she is having maximum restriction. See, this is the maximum lunch what she is having. This is the length. This is the maximum lunch what she is having. Basically, she is having maximum restriction. She is having what? Maximum restriction. Now, the question is that for 5 days, continuously, she was on diet. She was eating very, very less. She was eating very, very less for 5 days. Suddenly on a weekend, a friend came and she went on party. After that, she ate a lot there. My question is that after that, do you think she can start having what? Feeling of guilty? Yes. Now she will be having what? Feeling of guilty. Oh my God, I've eaten a lot. Oh my God, I have eaten a lot, right? I've eaten a lot. Now what she will do? Now she will be having what? Compensatory behavior. So even if she has eaten a lot, which is called as binging, but after that feeling of guilt will be there, right? So then she will be having what? Compensatory behavior. What are the compensatory behavior? Either she is going to induce the vomiting, basically the purging episode. She can use laxatives and all so that she can compensate for extra calorie intake. Let's learn these words. One is binging. Second can be a restriction. Binging means what? Overeating. Eating beyond fullness. When person is alone, she will be eating a lot. Basically, this is called as binging. But after binging, feeling of guilt. Oh my God, I have eaten a lot. Okay. What she will do then? Then there will be compensatory behavior. Right? There can be the purging episodes. What is the purging episodes here? So what are the purging episodes? To induce the vomiting, extra use of laxatives. Why there is the purging episode? To compensate for extra calorie intake. Easy to understand. So what I'm saying is that is either there can be maximum binging, either there can be binging, or there can be a restriction. Restriction means what? She is restricting herself more. She is not at all eating, right? She is eating only this much. This is called the maximum restriction. Okay, fine. So now you can understand the meaning of binging, meaning of restriction, and the meaning of compensatory behaviors. Now, let's understand the severity of this case. When I have explained you, after binging or after having food, after feeling of guilty, when a person is going to have what? When a person is going to have compensatory behavior like inducing the vomiting, right? When she is going to vomit out again and again, do you think there can be secondary complications because of the compensatory behavior? Yes. And we have to focus on the secondary complications because of the compensatory behavior. Very easy to understand. And for that, we have to treat the patient. Remember, these patients are this much image conscious, this much figure conscious, that they will develop depression. They will develop social phobia. They can have OCD. Suppose if mother is asking her, let's go to attend a marriage ceremony, she will say, no, see, how do I look? Oh my God, I do not, no, I will not go, because she will be scared. Oh my God, how other people are going to perceive me, how they are going to see me, right? So these people are what having? These people are having social phobia. Social phobia means what? Social anxiety disorder. Image, see, a fear of being watched. fear of being judged. What other people will say? What other people will say? How do I live? Oh my God, oh my God. So these kind of people can develop what? Social phobia. They can go into depression also. And remember here, because of these image consciousness and all, because of the social phobia, because of the depression, they can commit suicide also. Yes. Suicide is also seen in eating disorders. So now you can understand the severity of eating disorder, right? Let's understand the pathophysiology, types of eating disorder, and what will be the complications and how to manage the case. All right, chalo, fine. First of all, we are going to learn anorexia nervosa. Anorexia nervosa. What is the meaning of anorexia? Lack of appetite. But do remember here, appetite will be normal. Appetite will completely be normal. This is a misnomer. Appetite will be normal, but why she is not eating? Because she is image conscious. She is having fear of weight gain. Because most of the youngsters know they would like to become either Deepika Padukone or Angelina Jolie. But after eating disorder, they will have what? See, they will become what? Malnourished Angelina Jolie. With due respect. Easy to understand, right now? Fine. Let's understand what can be the complications. So first of all, anorexia. Okay, here you can see what? So maximum restriction. Bulimia nervosa, more binging, more purging episode. What this figure does indicate? This photo, what does it indicate? See, if you insert the finger into the mouth, and if you are going to touch the upper deeper part of the throat, yes, after that there can be vomiting, right? This is called the purging episode. Now let's understand how to differentiate anorexia nervosa and bulimia nervosa and what can be the complications, right? First of all, I will teach you with the help of some examples. I am having patient A and patient B. Patient A and patient B. Both are young girls. Both are young girls, 16, 17-year-old. Both are image conscious. Both have image consciousness. Both have image consciousness. Okay, fine. Now let's talk about, say, first of all, let's talk about patient A. Patient A. She is having maximum restriction. She is having maximum restriction. Maximum restriction means what? Not at all she is eating. Or she is, even if she is eating very, very less. Continuously for 5 days, full of gymming, full of exercises, full of, full on diet. Okay, fine. So basically she is eating very less, very less, maximum restriction. Or even once a week, or once in 15 days, if she is eating more than 1 plate or 2 plate, she is going to induce the vomiting, but maximum restriction. When she is having maximum restriction, do you think there can be situation like a starvation? Do you think there can be situation like a starvation? Starvation. What is the meaning of a starvation? As per the physiological meaning here, see here, in 1 day, see, for more than 24 hours, if a person is not taking solid food and liquid food, now person can have a starvation like situation. Basically maximum fasting. Okay. So when there will be a situation like a starvation, do you think there can be loss of nutrients? Do you think there can be loss of nutrients? Yes, there can be loss of maximum nutrients. So see here, when you can see that, yes, there can be loss of nutrients, let's understand this. Do you think there can be loss of carbohydrate, loss of fat, loss of protein, loss of vitamin and minerals? Yes, there will be loss of fat, loss of vitamins and minerals, loss of protein. Yes, there will be, see, there can be loss of the proteins. Yes, there can be loss of sodium and potassium. I can say that she can have dyselectrolytemia. Do you think there can be imbalance in hormone also because of the deficiency of these nutrients? Yes. Please write down here. Yes, there can be deficiency of, there can be deficiency of some hormones also. Deficiency of some hormones also. There can be hormonal imbalance also. Yes, there can be deficiency of luteinizing hormone, FSH. Okay. When there is imbalance in hormones, do you think there can be menstrual problem in females? Obviously, yes. Please write down, there can be amenorrhea. There can be amenorrhea. Right? Hypothalamic dysfunction is there. So yes, there can be amenorrhea, hypothalamic dysfunction. Now, because of deficiency, because of imbalance in these hormones, do you think there can be sexual dysfunction also? Yes, there can be sexual dysfunction, like there can be lack of libido. Yes, there can be delay in secondary sexual growth. There can be delay in secondary sexual growth. Very easy to understand. All right. When you have learned this much, now you tell me, when there will be deficiency of all these nutrients, do you think there can be weight loss also? Weight loss, yes. Yes, there can be weight loss. There can be weight loss. Weight loss, pakka. For sure, you should know this part. Weight loss, menses problem. All right. Now, when I have said here that when there is maximum restriction, there can be starvation. Physiologically, do you think because of the starvation, there can be compensatory activities in your body? Obviously, you know, during starvation, there will be metabolic changes in your body. There will be depletion of sugar. After the C, there will be use of free fatty acids. Finally, there will be what? More and more ketone bodies. Easy to understand, right? These are the compensatory changes after a starvation. So I can say that yes, after a starvation, yes. Now see, if you see liver function test, enzymes will be elevated. What about cholesterol? Yes, there will be hypercholesterolemia. Increase level of cholesterol. All right. Now, when I'm saying that imbalance of hormones, deficiency of all these nutrients, do you think bone marrow, bone mineral density can also be affected? Yes. Bone mineral density can also be affected. So there can be very high risk of bone fracture. Okay. High risk of bone fracture. All right. Now some other changes. See, I'm talking about patient A only, patient A. Now, do you think there can be edema also? Dependent edema in A? If yes, then why? Because there is a loss of protein. No, there is a loss of protein. Especially which protein? Especially deficiency of albumin. Edema will be there because of what? Hypoalbuminemia. Because of what? Hypoalbuminemia. What is the function of albumin? You would have learned in your basics of pathology. What is the function of albumin? Albumin maintains oncotic pressure. Albumin maintains what? Oncotic pressure. So when there will be normal albumin, there will be normal oncotic pressure. Decreased level of albumin will cause what? Hypoalbuminemia will be causing what? Decrease oncotic pressure, which can lead to increased hydrostatic pressure in the blood vessels. Because of increased hydrostatic pressure, what will happen? Small blood leakage, leakage in the vessels, and then there will be leakage of blood out of the blood vessel wall. Wherever there is a dependent part, there will be accumulation of blood. This can cause edema. So yes, edema will be there. Now, because of deficiency of so much of the nutrients, so much of the nutrients, even all muscles will also become weak. All muscles will also become weak. So even heart muscles will become weak. So now there will be what? Decrease in heart rate also. Decrease in heart rate also. Basically bradycardia, which after that there can be what? See, yes, so there can be decreased BP also, hypotension. Now there can see body temperature also, there can be hypothermia. If you see forearms, face and back of the patient, you can see development of a small hair, baby-like hairs. That is called as what? That is called as lanugo. That is called as lanugo. Chalo, all these points are clear to all of you. Now, what about patient number B? What about B? She is having more binging, more purging episode, more purging episode. Now, what is happening here? More binging and more purging. See, actually, when she is having food after 3 to 4 hours, she is realizing, oh my God, I have eaten a lot. I have eaten a lot. Right now, now she is going to induce the vomiting. She had the food. She had the food. But after 3 to 4 hours, she is realizing, oh my God, I have eaten a lot. I have eaten a lot. Now she is going to induce the vomiting. Now, do you think there can be a situation like a starvation? No. By that time, metabolism is over. So please write down here. Do remember here. Now there will be no situation like a starvation. There will be no starvation. There will be no starvation. Okay. Even so, if there is no starvation, do you think weight loss will be there? No, weight is completely normal. Weight is completely normal. What about sexual function? Completely normal. Completely normal. Libido normal. Secondary sexual growth normal. Everything is normal. Okay, everything is normal. Very easy to understand. Right? Okay, fine. Now, what about menses? Mostly normal, but in some cases, there can be amenorrhea also. Some cases there can be amenorrhea also. Now, do remember here, I have given you the example of 2 patients, patient A, patient B. Both are young and image conscious. A was having maximum restriction, where there was weight loss, amenorrhea, so there was the risk of, bone marrow fracture. Okay, all right, no, so loss of nutrients. B, more purging, more binging, more purging, no starvation, no weight loss. Like everything is normal, weight is normal, sexual function is normal, libido is normal, secondary sexual growth is normal, menses mostly normal. Okay. So remember, A, maximum restriction, more problems. A is anorexia nervosa. B, everything is normal. Everything is normal. Okay, more binging, more purging. It is what? Bulimia nervosa. I hope now you can easily differentiate the features of anorexia nervosa and bulimia nervosa. But do you think in bulimia nervosa there will be no complications? Obviously, there will be some complications. Let's understand the complications about bulimia nervosa. First of all, weight loss, amenorrhea, maximum nutrient deficiency will be seen in anorexia, not in bulimia. Bulimia, mostly all these symptoms will be normal. But what can be the complications in bulimia nervosa? Let's understand. Every day, when she is having food, or at least once a week, or 2 times a week, or 3 times a week, when she is having food, after that, she is having feeling of guilty. When she will be inserting finger into the mouth, when she will be inserting finger into the mouth, do you think over the knuckles there can be a scar formation? Yes, this is called as a Russell signs. There can be a scar formation. Yes, it is called as what? Russell signs. Russell signs. This is scar formation, erosion over knuckle. You can say calloused knuckles. Okay, all right. One is Russell sign. Second important point. When she will be inducing a lot, inducing the vomiting a lot, do you think there can be, see here, there can be the metabolic abnormalities? Yes, metabolic abnormalities. Mostly what? Mostly what? Metabolic alkalosis. Metabolic alkalosis. When she is inserting finger into the mouth again and again, do you think there is high risk of oral hygiene problem? Do you think there can be the risk of infection in mouth? Yes, please write down. There will be high risk of dental caries. There can be high risk of inflammation of the like salivary glands. So yes, there is high risk of parotitis, high risk of parotitis. Easy to understand. All these, see, remember, all these are more prominently seen in bulimia nervosa. But do you think these can be seen only in bulimia? No. At least once a week or once a 15 days, even in anorexia nervosa also, she is inducing the vomiting, although less, but she is also inducing the vomiting, right? No? So in anorexia nervosa also, you can see these signs, but more prominently in bulimia nervosa. More prominently in bulimia nervosa. I hope all these points are clear to all of you. Sometimes, see here, so what is happening is some extra points related to bulimia nervosa only. Again and again, if a person is vomiting out, do you think enamel of the teeth can be damaged? Yes, please write down enamel erosion. Enamel erosion. Yes, it can be seen in bulimia nervosa. And sometimes because of forceful vomiting, yes, there can be rupture of lower esophageal sphincter also. Yes, it can also be. So these are especially seen in bulimia nervosa. Now, every day if she was inserting the finger into the mouth or very frequently, do you think there can be severe inflammation of the parotid gland part also here? Yes, so there can be the parotid enlargement and face will become like this. Face will become like this. So what kind of facial appearance is this? This is called as chipmunk faces. Chipmunk faces. Chipmunk faces. Especially in bulimia nervosa. Enamel erosion, especially in bulimia nervosa. Lower esophageal sphincter rupture, especially in bulimia nervosa. Right? I hope all these points are clear to all of you. Now, see, in anorexia nervosa, I have mentioned weight loss. Weight loss. So when I have mentioned weight loss, do you think I should be emphasizing on BMI also, body mass index? Yes, body mass index also. How much is the normal body mass index? All of you, can you tell me? Bolo? Normal body mass index is 18.5 to 24.9. Now, if I write 25 to 29.9, overweight, this will be overweight. More than 30, it will be obesity. So what I'm saying here that in anorexia nervosa, weight loss will be there, no? So do remember here in anorexia nervosa, BMI will be less than 18.5. Less than 18.5. Now, let's have a fast revision. When I talk about two patients, patient A, patient B, anorexia nervosa and bulimia nervosa, situation like starvation will be seen where? In anorexia nervosa. So there can be hypercholesterolemia, right now. So there can be all compensatory changes. There can be deficiency of carbohydrate, fat, vitamins, protein, sodium electrolyte, hormonal imbalance, amenorrhea, weight loss, high risk of bone fracture. All right. And then edema. Okay. Then edema. Right? Then edema. and there'll be bradycardia, hypothermia, easy to understand, hypotension. All these complications will be happening in anorexia nervosa. But bulimia nervosa, more binging, more purging, no starvation, weight is normal, sexual function is normal, everything is normal. Mostly menses will be normal. Some cases there can be abnormality. Russell signs, metabolic alkalosis, dental caries, parotitis will be seen more prominently in bulimia nervosa than anorexia nervosa. But out of these two, if I ask you, which one is more common? Anorexia is more common or bulimia is more common? Remember, bulimia nervosa is more common than anorexia nervosa. Second question, if I ask you, if you see the complications, which one is more dangerous? Anorexia is more dangerous or bulimia is more dangerous? Obviously, you can see bone fracture, amenorrhea, weight loss, right? So remember, more dangerous is anorexia nervosa. Anorexia nervosa is more dangerous than bulimia nervosa. I hope all these points are clear to all of you. Now, some extra points. Anorexia nervosa is also of two types, restricting type and the purging or binge eating type. So more common is what? Restricting type. Okay. Bulimia nervosa, two type. One is called the purging type, means what? Where compensatory behavior is seen. Non-purging type means what? Where no compensatory behavior, but over exercises, over gymming, or over dieting. Focus on BMI. These days, we have to focus on ICD classification also and DSM-5 classification also. Do remember here that as per ICD-11, BMI should be less than 18.5. As per DSM-5, BMI should be less than 17.5. You have to remember both. Okay. Ideally, BMI is less than 18.5. Okay, fine. You can diagnose the case of anorexia nervosa. Okay. Now, one important point. When I talk about food handling behavior, what does it mean? Food handling behavior, what does it mean? Suppose if a young female, she is sitting on the dining table with a plate of food. When mother comes and mother is, hey, why you are not eating? Why you are not eating? No, I'm having food. You go, I'm having food. I'm having. After that, what she will do? Either she is going to hide the food or she is going to dispose in the dustbin. When guest will be coming, she will be making many dishes. She will offer everyone, but she will not eat. This is called a peculiar food handling behavior. This is classically seen in anorexia nervosa. Now, when I talk about ICD-11 and DSM-5, let's understand the update. I hope all of you know this fact that ICD-11 got updated last year only, 1st January 2022. This got implemented 1 year before. Okay, so there are some updates in ICD-11. Earlier, there were two criteria to diagnose. Anorexia nervosa. One was weight loss. Another was amenorrhea. Earlier, there were two criteria to diagnose anorexia nervosa. But now, as per ICD-11, only one criteria is there. Only weight loss is there. Only what? Weight loss is there. Only weight loss. Only one criteria, because even in anorexia nervosa, 68 to 89% people can have amenorrhea. What about boys? No. So remember, now there is only one criteria to diagnose anorexia nervosa. That is what? Weight loss, weight loss, weight loss. Okay. Now let's solve a question. After that, I can understand, yes, you have understood everything. Suppose if you are getting one patient in your OPD. Okay. A mother has brought 16-year-old daughter in OPD. Okay. Now, a mother is asking you, see, my daughter, she is not eating food. She is, she is not eating food. She is doing over gymming, over exercises. So when you do examination, on the examination, you can understand, yes, she is having image consciousness. She is having Russell signs. Russell signs is also seen. Third, menses normal. Menses normal. So far, what is your diagnosis? Your diagnosis is bulimia nervosa. But the fourth point, her BMI is less than 18. Now, what is your diagnosis? Now your diagnosis is anorexia nervosa. Now your diagnosis is what? Anorexia nervosa. Very easy to understand. Fine. So you should understand that now there is only one criteria to diagnose anorexia nervosa. What? Weight loss. Weight loss. All the complications I have explained you. All the complications I have explained you related to anorexia nervosa and bulimia nervosa. Now you should understand, if I ask you one question, which patient you should be hospitalizing? Only anorexia or bulimia nervosa also? Who needs hospitalization, by the way? You have to focus especially on weight loss. Weight loss. Remember, hospitalization is needed in anorexia nervosa. Hospitalization is needed in anorexia nervosa. See here, first of all, weight loss is the most important concern. Dyselectrolytemia is the most important, second most important concern. Okay, there will be what? Severe dehydration also. Right now. So let's understand this part. Anorexia nervosa hospitalization is needed, especially when I see weight loss is there. When I see weight loss is there. Okay, weight loss is there. Okay, now how to treat the patient? You have to increase the calorie. You have to admit the patient. Increase the calorie by 500 kilocalorie per day. You have to increase more than the normal, 1500 to 2000. More than the normal, you have to increase 500 kilocalorie extra, 500 extra. After that, so patient was admitted in my hospital for last 1 week, but there is no improvement. No improvement. Why? Because I missed one point. I did not give proper instruction to my nurses that you have to supervise her after taking meal. Supervise the patient for 2 hours after meals. She should not be going to toilet. She should not be using washroom after taking meal. Why? What she was doing? Why there was no improvement in weight? Why? Because every day she was inducing the vomiting. So you have to increase extra calorie 500. Okay, 500, and every day 2 hours supervision after the meal. Easy to understand, right? After the meal. Very, very important to understand. She should not enter the washroom at least for 2 hours, because within 2 hours metabolism will be over. After that, behavior therapy. We have to motivate the patient. We have to motivate the patient. We have to make her understand that food is very, very important. Food is very, very important. You have to focus. Okay, like say this is so good. This is delicious. This is this is that. Live healthy. Stay healthy. Okay, eat well. Is it motivate the patient to eat the healthy food? Apart from that, we have to add a medicine, especially SSRI. I hope you know about SSRI, which is going to increase the serotonin. In basic physiology, you have learned serotonin is responsible for good food, good mood, and good sleep, right? So SSRI, especially which SSRI? Remember here, especially fluoxetine. How much dose? 60 milligram in 1 day, 60 milligram, okay, per day. So basically SSRI, very, very important drug. You can also use a TCA like imipramine, okay, imipramine. What about why we can see sometimes we can also use cyproheptadine or antipsychotic. Olanzapine. Hey, what is the use of olanzapine? Antipsychotic in eating disorder. What is the use here? Side effect of olanzapine is what? Side effect is weight gain. Side effect is weight gain. Okay, so low dose of antipsychotics can also be used. Okay, so cyproheptadine and olanzapine, purpose of using these drugs as per the situation. Yes. So what is the purpose? To increase the weight. Bulimia nervosa can be treated on OPD basis. Always remember that main line of management is behavior therapy, psychotherapy. Motivate her to eat well. If patient is not responding, then we can use SSRI and TCA. Which SSRI? Same, fluoxetine. Which TCA? Imipramine. I hope all these points are clear to all of you. Now, the question is that, suppose if there is a very slim, trim girl in your OPD, very slim, very trim, very much thin. You ask her, hey, you are not eating food, right? You are on diet, huh? So, no, I eat, doctor, I eat well. Why? Because most of the patients will lie. So that's why we have a questionnaire system that is called as a SCOF questionnaire. This time, INICT question. This time, INICT question. One-liner question was there. INICT 5th May 2023. SCOF questionnaire is used for which of these psychiatric conditions? Which one? Eating disorder. SCOF means what? You ask some questions to the patient. Do you feel sick that you have eaten a lot? Do you think that you have lost the control over amount of food you eat? Do you believe, or do you think that you have lost 6 kilograms? Have you lost 6 kilograms in last 6 months? Over 1 stone. As per European parameter, 1 stone is equal to 6.3 kilogram. Have you lost 6 kilograms in last 6 months? Do you believe that you are fat when others are saying you are thin? Do you think food dominates your life? Out of these 5 questions, if she is answering yes for equal to or more than 2 questions, it means 100% she is suffering from eating disorder. And there should be the proper, okay, there should be proper evaluation. This is called as a SCOF questionnaire. At the same time, I can have a good revision of, like some other questionnaire which we are using in psychiatry. I hope you remember about CAGE questionnaire. Where do we use CAGE questionnaire? In alcoholism. MCHAT questionnaire. Where do we use MCHAT questionnaire? In autism. Please remember at least these 3 points. Now you can understand how to manage anorexia nervosa and bulimia nervosa. Let's discuss some more small eating disorders. When you look at this man, do you think he wants to become Hrithik Roshan in future? When you look at her, do you think she wants to become Deepika Padukone in future? No. Binge eating disorder, most common. 40 people these are. So there will be no image consciousness. Overweight and obesity will be there. So how to differentiate bulimia nervosa and binge eating disorder? Compensatory behavior will be seen in bulimia nervosa, not in binge eating disorder. Weight will be normal in bulimia nervosa, and weight will be increased in binge eating disorder. How to treat binge eating disorder? Mostly psychotherapy, behavior therapy. Okay, fine. All right. Now, these people, they also do not eat. These are new eating disorders which are, see, and now the eating disorders which I'm going to teach you, these are new eating disorders added in ICD-11. ICD-11. They also do not eat. So they also have weight loss and nutritional deficiency, same like anorexia nervosa. But the question is why they are not eating the food? They do not like the taste. They do not like the smell of food. So the food which they do not like, if they offer them, when they will eat, no, they will feel some kind of obstruction in their throat, and they will meet ENT specialist. ENT specialist, sir, I think some problem is there in my throat, sir. Some obstruction. I think, I'm having some problem in swallowing. When examination will be done, everything will be normal. This is called as what? Functional dysphagia. Functional dysphagia, also called a globus hystericus. Why she is not eating the food? Because she doesn't like the taste or smell. That's why she avoids and restricts. That's why it is called as what? Avoidant restrictive food intake disorder. Food intake disorder. They also have weight loss and nutritional deficiency, same like anorexia nervosa. But what is the difference? Here, no image consciousness. No image consciousness. These people are not image conscious. These people are what? Not image conscious. Okay. So I have taught you 4 eating disorders so far: anorexia nervosa, bulimia nervosa. After that, binge eating disorder, and that what? Avoidant restrictive food intake disorder. See, if image consciousness is there, weight loss is there. What is the diagnosis? Anorexia nervosa. Image consciousness, weight is normal. Bulimia nervosa. Overweight, binge eating disorder. Weight loss is there. No image consciousness. Then what is the answer? Avoidant restrictive food intake disorder. Now, next disorder is pica. What is the meaning of pica? Appetite for non-nutritive substances. This is a psychological disorder. You might have seen a child who loves to eat, brick, clay, blackboard, and chalk, clay. So first of all, age of a person should be more than 2 years. Symptoms should be persisting minimum for more than 1 month. Okay. Okay, fine. Very easy to understand. Now see here. What are the pica disorders? Suppose if a person loves to eat ice, it is called a pagophagia. Eating earth, clay, geophagia. You were learning about geography, no? Study of earth is called a geography. Eating earth is called a geophagia. Eating hair is called as trichophagia. There is an OCD disorder. Now OCD disorder, hair pulling disorder, what it is called as? Trichotillomania. Earlier, it was considered as impulsive control disorder, but as per ICD-11, now it is a type of OCD. Hair pulling is called a what? Trichotillomania. Person can eat the hair also. That is called a trichophagia. So what can be the complications? Now, do you think there can be hairball obstruction? Yes. That is called as trichobezoar. What is the most common location of hairball obstruction in GIT? Duodenum part 1. This is also called as Rapunzel syndrome, which you will be learning in general part of surgery, right? Okay. So how to treat trichobezoar? Surgical removal only. Eating paper is called as xylophagia. Sharp objects. See, like when you talk about Beijing, Shanghai, in China, they do acupuncture, inserting sharp object. Eating sharp object is called as acuphagia. Eating metal, metallophagia. Eating stones, lithophagia. You would have learned in general part of surgery, neurosurgery, ESWL, where you'll be learning about lithotripsy. Breaking the stones, lithophagia, eating the stones. Glass hylo. Some mentally retarded people can eat fecal matter also. Coperophagia, right now? Coperophagia. Vomiting, emetophagia. So here you have to rule out mental retardation, IQ and all. Some people can, like some kids can lick wall paint, also dry wall paint, brick and chalk also. So do you think there can be complications of pica? Yes. Yes. So what can be the complications? What can be the complications? Please understand this. What can be the complications? See, if a child is eating clay, earth, fecal matter, do you think there is very high risk of any infection? High risk of infection? Yes. Especially which infection? Toxoplasma infection. Okay, especially what? Especially, so here at one place I can write toxoplasma infection. When a child is licking wall paint, do you think child is at the risk of any poisoning? Yes, wall paint, what is there? Wall paint may lead will be used. So do you think child is at the risk of lead poisoning? Yes, lead poisoning. Lead poisoning. Lead blocks heme synthesis, two enzymes of heme synthesis, ALA dehydratase and ferrochelatase. So lead poisoning, yes, lead will destroy myelination of nerves. Lead can cause encephalopathy. Okay, lead can cause hyperuricemia also, so gout. So yes, person will be at the higher risk of lead poisoning also. Now, what about hairball obstruction? Yes, there can be surgical complications, acute abdominal pain, GIT, bleeding, right? So surgical alteration will be needed. Very easy to understand. I hope all these points are clear to all of you. Now, one more last eating disorder, which I want to emphasize. You would have seen a child that, first of all, he is going to eat. First of all, he is going to swallow the food. After that, intentionally, what he will do? Intentionally, what he will do? He's going to take it back. Intentionally, he will be bringing up the swallowed food back into the mouth. After that, he will re-chew the regurgitated food. Obviously, age of a child should be more than 2 years. Easy to understand. This is called as rumination regurgitation disorder. This can result into nutritional deficiencies. In total, I have taught you 6 eating disorders. Now, can you solve some questions so that you can have complete clarity? Anorexia nervosa can be differentiated from bulimia nervosa by, out of these 4 options, see the options. What about option number D? Food handling behavior will be seen only in anorexia nervosa, not in bulimia nervosa. So answer is D. Which of the following is false regarding bulimia nervosa? See the options. What about option number C? Amenorrhea is a common finding in bulimia nervosa? No. Amenorrhea is a common finding in anorexia nervosa, not in bulimia. This is one-liner question. Which of the psychiatric illnesses is more common among females? Eating disorder. Eating disorder. Which of the following is not a common feature of anorexia nervosa? Binge eating more commonly seen among bulimia nervosa patients. Which of the following is a differentiating feature of avoidant restrictive disorder and a restrictive type of anorexia nervosa? Weight loss, nutritional deficiencies, insufficient intake of food. All these we can see in both, but body image consciousness will be seen in anorexia, not in avoidant restrictive food intake disorder. Now see this last question. This looks like NEET type of question. Big question. If you can solve this question, it means you have understood all the point. 15-year-old mother, she was brought to OPD by her mother. Okay. On examination, see here, body mass index is 17.5. Russell signs, yes. Mother is reporting that she's indulged into rigorous exercises and over gym. Basically, image consciousness is there, right? During interval, girl is irritated and saying that she is doing good and eating fine. On further inquiry, it was found that she did not had a menses. What else you want? What is the diagnosis here? Simple. Image consciousness, weight loss. Okay. Russell sign, sometimes it can be seen. Yes. Okay. So answer is what? Anorexia nervosa. Anorexia nervosa. In this manner, we have completed each and every all parts of eating disorder. I hope you have learned something and you have learned how to manage eating disorder case. Thank you so much. Have a good night. Bye-bye.